Welcome everybody to our first Launceston Patient Forum. We have done one other in Hobart pre-COVID, so we just thought the man of the moment over here, young Rob, who is doing all this wonderful fundraising to get a net nurse in Tasmania. He had his fundraiser last year and raised about 50,000, and this year he's hoping to get about 80,000. But he has been relentless and focused and just totally advocating for neuroendocrine patients. So we want to say thank you to Rob so much for everything that you're doing, and yes. Don't get teary. No. He's a big softie. So anybody that would like to come to the race afterwards, there are some tickets still available. So just let us know, and it's out at Mowbray, starting first race at 5:25. Yep, excellent. Okay, so I'm Meredith Cummins, and I am the CEO for NeuroEndocrine Cancer Australia. I've been working with NeuroEndocrine Cancer Australia for 5.5 years. It was previously called the Unicorn Foundation, and we decided in 2020 that we would change the name because everybody sort of, if you met them, you said where you worked, and they went, well, what's the Unicorn Foundation? And you'd say, neuroendocrine cancer. And they go, what's neuroendocrine cancer? So we thought we'd cut one, what is it, down, so that when they say, where do you work? NeuroEndocrine Cancer Australia. And then they sort of, then it's, what's that? And then we could get on with it. So I'll go into some of the activities that we're doing at the moment. We've also got Adi sitting, having something to eat there, who is our marketing and communications manager. And I'm sure a lot of you have had interaction with her as well. We are a very small group. We've got 7 staff and only 3.8 full-time equivalents of those 7 staff, so there's only 2 of us that work full-time and the rest are part-time. So as people have been quoted to say that we punch above our weight and we run on the smell of an oily rag, and so far all our funding has come from donations from you patients. So we're extremely grateful, and we're keen to get more money and get the government to support us like they support other cancers. So one of our missions today was to meet with the Health Minister, which we did this morning, and we think that we've had a good outcome. So, but we'll just have to wait and see. And then we've got our distinguished other guests here, Janie Finlay, Anita Dow, and up the back is Liz Bowman. So yes, welcome, and thank you so much for being here, and thank you for all your support that you have given us. I will actually thank Novartis as well, because they've helped with paying for the filming of this so that we can then share it on the website with everybody. So I think that's enough of the sort of background things. So I'm going to start off with NeuroEndocrine Cancer Australia, what we're doing now. So just a bit of a snapshot of what neuroendocrine cancer's survival rate and also the incidence. So as you can see there, this is the most recent numbers that have come from the Australian Institute of Health and Welfare. And as you can see there, neuroendocrine tumour, there's 5,556 new cases in the last year. And then you look at the other cancers like pancreatic and leukemia. So you can see that we are not a rare cancer. We are actually a less common cancer, but we're a very misunderstood cancer, and sometimes with the government, invisible. So we want to make sure that we're not invisible anymore. So the 5-year survival rate is 51%, and that's sort of looking at all the different grades of neuroendocrine tumour and then the mean of that. So for the grade 1s, the survival rate is a lot higher for 5 years, but for the people who have got grade 3 neuroendocrine tumour or neuroendocrine carcinoma, the survival rate is not as high. It can affect both men and women from any age after 15. So just another little bit of information about neuroendocrine. 30% of patients live 300 kilometres or more from the closest centre of excellence, which is a big stat. There's 1 in 55 Australians have a chance of developing a NET. It is the 7th most commonly diagnosed neuroendocrine cancer in Australia. There's 25,551 plus Australians living with NETs. I've already done the survival rate. 1 Australian is diagnosed with neuroendocrine cancer every 90 minutes. And the average wait time for a correct diagnosis is 5 to 7 years. So 1 in 2 patients originally diagnosed with something else, and unfortunately 60% of patients are stage 4 by the time of diagnosis, which means that it's spread to other organs such as the liver.
Meredith, sorry to interrupt, but where is our closest centre of excellence?
The closest centre of excellence is Peter Mac in Melbourne. So there's 5 centres around Australia. So there's Peter Mac, and that's been accredited by the European Neuroendocrine Tumour Society. Royal North Shore, which is also accredited with ENETs, and then there's Royal Brisbane in Brisbane, Fiona Stanley in Perth, and Queen Elizabeth in Adelaide. So they're the main 5 centres around Australia.
Excuse me, Meredith.
Yep.
As well.
Yeah.
You said there that it can affect anyone from 15 years or older. My son was 12 when he was diagnosed. Yeah. So I know that's kind of an average, but it can affect younger.
Absolutely.
As well.
And if you look at neuroblastomas, that's for small children and everything. So that's a generalisation. But thank you for that point. Okay, so just an introduction to us is that we're champions of early diagnosis and a cure, and our mission is to support and assist patients and carers, and that's through support groups and also access to networks of expertise. We also lobby for access to new and appropriate investigations and treatments. We raise awareness and knowledge with the medical community and general public, and I'll go into these in a bit more detail with what we actually do to achieve those, and encourage and support research in the areas of neuroendocrine cancer, which is our Planet Registry, and there is a new study we're commencing, which is the AusNet, which I'll also go into in more detail. So with the patient support, I think some of you would have already had some contact with us, but the NET Nurse Support Line, we have 2 nurses who work job share for a full-time position. So that's Monday to Friday, Eastern Standard Time, 9 till 5. And there's an average of 200 contacts per month. And this number has been increasing by about 25% each year. But it has actually gone up more since we've been doing the awareness campaign, which commenced 3 months ago. We've also do a lot of resources, and there's 2 explainer videos, and we've got one on PRRT, the peptide receptor radionuclide therapy, which is what people from Tasmania go to Melbourne to have. So we're putting together an explainer video of what PRRT is, and it'll be just animated and it'll be plain English so that you can understand what's involved. The 2 that we've got is what is the neuroendocrine system, and then just talking about neuroendocrine cancer. And that has actually been translated into Mandarin and Arabic as well to try and sort of reach a bigger audience. We do support groups across Australia face-to-face with local groups, and there's also the national Zoom meeting, which we have at different times so that it can accommodate people who are working or other things that happen in people's lives. We've got, sorry, there's a typo there. Facebook private group is actually 1,800 active members, not 8,700, so sorry about that. And NECA remains the main referral service for NET patients around the country. So Cancer Council and all those, whenever they get a NET patient, will refer through to us. So just with research, we're really actively involved with helping to do that, and also with recruitment. So the Planet Registry is a registry that is just a clinical database that we've got in the 5 centres around Australia, and it's just recording everything that will be in your normal medical record, so that we can then look at sort of all the different aspects of neuroendocrine cancer types and treatments and everything, so we can look to possible areas of further research or getting ideas of locations and hotspots and all that sort of thing. With the Planet Registry, patients are actually able to have an app on their phone which they download, which has quality of life questions in it, It's also got the Bristol stool scale, so for those who don't know what that is, it's a poo scale, and you can actually slide along your phone and it does the 7 different types of poo that you can have, and you can record when you're doing it, how frequently you're doing it, and it all gets recorded, de-identified to Melbourne University, where they can actually provide reports for us. But all those that data that goes into the app, the doctors, when they're doing consults, can actually have a look at it, and it maps it out. So they can look at areas that sort of, there might have been worsening of fatigue or worsening of diarrhoea, and then can work out sort of whether there are any triggers to go along with that. So we're hoping to get that happening more. COVID really killed us with that, because a lot of patients weren't able to go into the hospitals to see the doctors and get recruited, and plus data management and research was sort of grinding to a bit of a halt during COVID. The AusNet Nurse-Led Shared Care is a project we're doing with Flinders University. So we have one of our nurses who's the project officer working with Flinders University, and each of the nurses that are specifically for the 5 centres around, and when the patient's case is actually discussed and the management plan is done, then our nurse and the nurse that's at the hospital will speak with the patient, and then we will have a case conference with the GP, so that the GP knows what's happening with the patient. And that way we're hoping to close the loop on everybody sort of being well informed. So that's just about to commence in Adelaide. There's another project that we're doing is with Ipsen, and that's called Treatment in the Community, and we're doing patient stories so that we can actually get people's stories out to other patients, so that it's just sharing of information, and it helps just to sort of bring tips and just the way people are dealing with their net in the community. We've been working with Melbourne University as well for a menopause study, which we thought would be extremely interesting to be part of, because one of the signs and one of the symptoms of neuroendocrine is flushing. So is it happening because it's menopause? Is it happening because it's neuroendocrine cancer? So it's the first time we've been included in a study like that, so we're really keen to see what's going to happen with that. At the moment we've got an intern project with communication and a treatment pathway with the optimal care pathway, and you would have seen in the newsletter and also on the, I think there was an email or website that she's doing interviews, and so we're looking at sort of the pathway through of people having neuroendocrine cancer, and since we've got the optimal care pathway, whether that's actually been included in the management of patients. So if you're not aware of the optimal care pathway, you can go onto our website and click onto it. There's a very lengthy document which is about 72 pages, which we had a team, and neuroendocrine cancer was one of the main stakeholders to write that, and it's housed through Cancer Council Australia. And there's also a 4-page quick reference guide for GPs, which is giving them timeframes of when things need to be done. If they're suspecting a neuroendocrine cancer, of what they should be doing as far as the tests and everything beforehand. So it's a really good guide, and there's also a consumer guide for reasonable timeframes for everything to be completed as far as tests. So all around it's really good. There's another study that we're hoping to get happening soon, which is called Genetica. So it's looking at genomics. So we're looking at sort of, whenever somebody's got a neuroendocrine tumour, looking at those cells to look at prognosis, you know what's the outcome for that patient. Also hereditary. So we're looking to biobank a lot of the tissue and blood as well. And it's a study that we're also looking at doing with Canada and New Zealand, so that we can get a really big picture. So education, we've got the RACGP accredited modules, which we've got the flyers up on the table there. It's free, it's online, so please feel free to take some of those along and give them to your GPs, because we've had 3,100 healthcare professionals complete them since we started them, and that's including nurses. And we've opened it up to other doctors. Anybody that has an APRA, a registration number, can do it. So, and you get a certificate at the end. We've had funding, a one-off from Mr. Butler's office for a national awareness campaign and patient resources. We do a lot of education online to doctors, nurses, so that we can just get an overview of neuroendocrine and just give them information. There's the Patient Living with NETs program, which I'm not sure, I think a few of you might have done, or it's in progress at the moment, but we're running it 3 times a year. We did a pilot last year and it was extremely well, response was fabulous, and we just want to keep rolling that out. But it's online, it's 4 weeks for 2 hours, and it's a good learning experience because we have patients who are old patients and new patients, and then they can share tips and tricks together and talk about their experiences. And we also give information about sort of diagnosis, consultations, navigation, treatment, and then living with NETs of various things. Okay. We also do a lot of conference presentations, and we've also hoping to put together, in collaboration with a couple of other organisations, dietitian education modules. So that's in the planning. So there's a lot of dietitians out there, but not many NET specialist dietitians. So we really want to get the information out to all of them. So living with NETs, I'll flick through that, but I've just gone through that, but just the feedback was 95% from pilots where information was easy to understand, it was useful, and it was really good with managing side effects and treatment, and they felt comfortable in asking questions. I'll flick through that because we've also got the National Action Plan, which was distributed, I think, in 2021 on World Net Cancer Day. There's a couple, or one left up there, but you can download it off the internet. But the areas that we really wanted to look at was getting NET specialist nurses, one for each state we were looking at, and still are. Increasing the information and resources. This is what the awareness campaign, that was one of the actions that the government has funded. We also have got education of healthcare professionals, and we want to increase, and we actually want to get all the information out into the universities for the medical students so that we can get them learning about it a lot earlier. The National Awareness Campaign is what we've been funded as well. The Optimal Care Pathway has been done. Data registry is there, but it's not as good as we would want it to be as far as the uptake. We want to get more centres of excellence, and we also want to have more targeted research. So we're busy meeting with MPs around Australia, and if you want to organise for either a state or federal MP that you would like to approach, then we're more than happy. If we can, we'll come in person, but if we can't, we'll Zoom in, and they always listen to the patient's story, but we come in sort of from the organisation's point of view as far as being able to help you. So what we're doing now is the National Awareness Campaign, and you've possibly seen a lot of this. Consider the grey area, so NETs are not just black and white, and all the little splotches on there with the camouflage are all the symptoms that patients frequently get. The Senate inquiry, we have submitted that, and it is available through the government website to have a look at, but we really pushed for everything that we possibly could, especially looking at CGA, which is not funded, whenever you have that done, to get that put on to Medicare, and just a whole gamut of whatever we could go for. Medications that might not be available to some groups of NETs, and I know anybody that has a lung NET and then haven't got carcinoid syndrome cannot qualify for lanreotide. So we said if they've got a lung NET, they should be able to qualify for lanreotide because they've got a NET. So there's just things like that that we're really pushing for. We've been involved with MSAC consultations and various other consultations as well. So we're just really, really working hard to get the voice and everything out there. So your stories and interviews and everything like that are really important. So Heidi's always getting lots of and chasing up people to get more stories, because the more stories we've got about you, the more we can do and the more we can advocate. And so far, this is just with the awareness campaign. We've got a lot of digital advertising, which has been amazing. We've gone from
3,000 people a month to our website to 22,000 people a month in 3 months.
Yeah.
And a lot of people now are important.
Yep. So really pushing. We've paid for additional search engine optimization, and Thomas was just telling me that he'd gone in and we were sort of up there, but we could still be up there a bit more. So we just want, whenever people go into Google, want them to come to us. We've been doing podcasts. I think the most exciting thing was Michael Usher, who is a senior journalist on Channel 7. I actually ran into him at a cocktail party, and I thought, I'm going to get you. So I had a chat with him and I said, is there a chance that we could do a story on Latest? And he said, sure, let's organise it. So we got Dr. David Chan from Royal North Shore to come in, and he interviewed him, and we've had amazing feedback from that. But it was also from that we managed to have a patient who was at the point, has a hearing difficulty with the masks that are on when having a consult. She couldn't lip read what the doctor was saying. She was getting more exasperated by things. The doctor was almost sort of saying, you need to go and have a psychiatric assessment. And when she went home, her mother had sort of watched the video and said, that's what she's got. So they took the recording to the GP. She since has been diagnosed with a neuroendocrine cancer. So it was just through the fact of sort of, the symptoms and drawing it out. But yeah, the difficulties of people sort of having to deal with not being able to understand or communicate has really helped with having that. And plus we managed to get him as an ambassador for us. So that's a big plus. So we're doing lots of public relations campaigning and lots of education, and we've got lots of flyers and everything, and we're just hoping to get more and more out there so that everybody, when they see neuroendocrine cancer, they understand it and they know to help us, and that the government will help us. And I just sort of just give you a quick update on somatostatin analogues, so anybody that's on them. The eShine program, which was the program for Sandostatin LAR, that actually finished on the 30th of April. But if there is anybody, and hopefully not by now, but if it's anybody that needs help with getting their injections organised, we can work through Novartis to get their healthcare professionals trained up for that. Ipsen still has a home injection program, but it's sort of been cut down a little bit, but they're still available to teach healthcare professionals, and if somebody hasn't got somebody to do an injection, then they will supply a nurse. And as of the 1st of August, there was a generic lanreotide that came onto the market, but that's doesn't have a home injection program. And there's also a study going at the moment called Sorrento, which is a new somatostatin injection. It's on trial at the moment, and I think they've nearly reached their capacity for the trial, but the syringe is like an insulin syringe. It's really small, and you can self-inject, and it also doesn't need to be refrigerated. So we're seeing that as an absolute groundbreaker as far as care for NET patients, because half the trouble when you want to travel is how do you keep your injection cold, or you have to work everything out around your injection. So we're hoping that this is going to be really successful. So with this, I just thought I'd show you, this is a combi that one of our patients, afternoon, this is one of our patients. We did a presentation to one of the pharmaceutical companies, and he told his story, and I think quite a few of you that are on the Facebook group, that you're on the Unicorn bus. So this is his bus. So everybody needs to get on the bus, but they also need to drive their own bus. So yeah, I thought it was a wonderful analogy. So thank you so much for listening to me babble on. So before I actually introduce Thomas, I need to ask Anita to come up and say something very important. I won't let the cat out of the bag.
Thanks, Meredith. Well, Janie and I are very pleased to be here with you this afternoon, and I'm your Shadow Health Minister with the Tasmanian Labor Party, and Janie is one of your local members for the seat of Bass. And today we've been working with Rob for the best part of the last 12 months really, and I first met Rob through Janie, and he's been a tremendous advocate on behalf of all of you for a better awareness and more funding for better support programs for Tasmanians living with neuroendocrine cancers. And so today we made a very special announcement where we will fund a NETS nurse for Tasmania should the Tasmanian Labor Party win the next state election. So we wanted to, that would be a statewide position, and we obviously would work very closely with NECA, with Rob and with all of you to ensure that that position met your needs locally and actually fulfilled that really important support role for you. So we were really pleased to do that, and we felt that it was fitting to do that on a day like today where we had this forum here in the north of the state, but also in line with Rob's race and fundraising race again this afternoon. So I guess if any of you have got any questions about that, please don't hesitate to get in touch. Janie and I always make ourselves available, and I'll just hand over to Janie, who might like to say a few words as your member for BAS.
Yeah, thanks Anita. It has been it's been a really big year having these conversations with Rob and finding out more and more about NETS. It's meeting with Meredith and Adi and on Zoom calls and getting to understand really, and actually today meeting with people in the room today and hearing your stories just really reinforces how important this announcement was today. And for me it seems like it's not real to hear that things are misunderstood and they're sort of hidden and not diagnosed straight away in the right way, and that in this day and age that seems like it seems a little unbelievable. So for us working over this last year, Rob has been just an absolute warrior, relentless, and often I felt I worry for Rob. He comes across strong, but often potentially to his own detriment, the work that he's been doing, but with the support of Meredith and with Adi, really understanding how important this is. And I would like to say, through Rob, I know that Tasmanian Labor are really proud about this, but Lara has been, really strong in her understanding as well and her support for this. I know Bridget as well has also been really important. So we're all trying to do what we can for Tasmania, and we're hopeful that when we are elected and we are in government, that it happens. But also sometimes from opposition, the benefit of being able to make announcements like this is actually that it gives the government a wriggle along. And so there is no reason why not today they can't make this decision as well. So thank you for allowing us to be part of your journey and story. And thank you, Rob, for the work that you're doing and for the people today that have shared your story. It's actually really powerful for us and keeps us going with the work that we do as well. So thank you.
Thank you. So, I will now. I'd like to introduce Dr. Thomas Block, and he's a second year endocrinology advanced trainee based at Royal Hobart Hospital and adjunct research associate in the Monash University Department of Diabetes in Melbourne. He regularly manages patients in the endocrine neoplasia clinic alongside Professor John Burgess at the Royal Hobart Hospital. His research interests include novel therapies targeting diabetic cardiovascular and renal disease, obesity management, and metabolic bone disease. So in addition to having published articles in these areas, he has received several national and international research presentation awards, including the Australian Diabetes Society Best Clinical Presentation Award in memory of Dr. Paul Lee in 2022. He is also the recipient of a Heart Foundation Vanguard grant and remains the chief investigator of a prospective clinical pilot study exploring the utility of prognostic biomarker for oxidative stress in patients with diabetic cardiovascular disease. Oh, that's a mouthful. Thomas intends to commence a PhD next year and relentlessly striving towards his future aspiration as a clinical researcher. So welcome, and thank you so much for doing your presentation. Have I got a pointer? No.
That's okay. Do we want the microphone?
You want to do the microphone?
I think it might be okay.
Should be? Yep.
Just say a few words.
Yep, well.
That's great. Carry on. We can
I'll
carry
just
on.
put up the presentation.
Yep, that's working fine. Thank you.
Alright, so. So before I begin, thank you all for joining us today in this forum. I think it's really important that we raise awareness for this, very somewhat thought to be rare but actually quite common cancer in Australia. And I also want to thank Meredith for giving this opportunity to present. Very happy to discuss. And as I said, this is going to be a very general overview. If we have any more questions later, happy to answer them in the Q&A. And there's some fantastic resources on the website for any more info. So, as Meredith already alluded to, I'm not going to go into detail, but we know that this condition is very common. And I guess the point I'm trying to make here is the average Australian waits over 5 years to have a correct diagnosis. And that's the whole point of this, or these forums, is to really raise awareness and get people to recognise the symptoms, some of the causes, some of the genetics, as well as the family implications with a lot of the diseases that I'm going to present today, and really try to get people on board with screening and other genetic ways of being able to manage this condition early, so that people can then have a better chance for a cure or disease remission for as long as possible. Really briefly, I know most of you will know this, but just to summarise, when we're talking about neuroendocrine tumours, we're really talking about tumours that are developing in a lot of the neuroendocrine organs in the body. So really depending on the condition and disease, we've got in the brain, the pituitary, the thyroid, the parathyroid, some in the lung, adrenal glands, pancreatic neuroendocrine tumours, as well as a lot of gastrointestinal tumours that can occur anywhere in that vicinity. And there's many types of neuroendocrine tumours. This is by no means an exhaustive list. These are sort of the main ones, and I'm sure many of you in the audience have been diagnosed with one or more of these neuroendocrine tumours, or know someone or have family that have been diagnosed. So really, it can be broken down into the location of the neuroendocrine tumour. You can see that there's some that are in the gastroenteropancreatic region. Some of them can be functioning with carcinoid syndrome, some of them can be non-functioning. There's also pancreatic neuroendocrine tumours, and these are really subcategorized in the hormone that they produce. So you can see a gastronoma will produce excessive gastrin, insulinoma, excessive insulin, VIPoma, excessive VIP, and that can cause what the neuroendocrine symptoms you experience, because you've got excess of this normal hormone which is causing the symptoms. And then we've also got multiple endocrine neoplasia, or MEN, that is also many subtypes which have different manifestations of clinical disease. And then we've also got the pheochromocytomas and paragangliomas, which can be due to by themselves or also as a syndrome of another disease, as we can see here. And there's also Merkel cell carcinoma in this list. So really looking at the causes, and today I'm going to be talking about the genetic causes, but as you can see, as with any cancer, and not excluding neuroendocrine cancer, really it's the age that is one of the most significant risk factors. So as you get older, as your cells age, there is a chance for more genetic mutations, and as you build up these mutations, there is a higher risk of cancer. That's why, in general, in other cancers, you hear about people being diagnosed, in the 40s, 50s, 60s, 70s, rather than early on. But with neuroendocrine, I guess the difference is there that a lot of them are genetic, so you do get really young cases, even children. And so that is a very strong risk factor. As you can see, though, there are other causes such as hormonal factors, environmental factors, behavioural and lifestyle factors. But I think a lot of people with neuroendocrine tumour shouldn't feel such that their lifestyle or the environment or other things have caused this cancer. A lot of the times it is genetic, or there's a family history, but there's always a component of that in sort of every cancer. But certainly this is why recognising things early, including the symptoms, we'll be able to get down to the diagnosis, and then we can start treatment and other management. So yeah, that's it. We'll be talking about genetic factors today. And so interestingly, if you took all the people with neuroendocrine tumours, the vast majority wouldn't have any hereditary risk factors, and by that I mean they wouldn't have any sort of genetic family type history. That's in general. But obviously with a lot of the patients we see in our clinic, there are a lot of familial syndromes which I've listed there. This is, again, not an extensive list, but certainly if you have one of these conditions, or you have a family member with one of these conditions, or and even if this family member is not a first degree relative, you certainly can develop there's a much increased risk of a neuroendocrine tumour. I'll go into some statistics in a few slides, but essentially, these are sort of the risk factors. So if you have someone with this sort of condition or you've been diagnosed, then you've got a greatly increased risk of developing a specific type of neuroendocrine tumour depending on the type of familial syndrome you have. So, looking at it, we've got MEN, von Hippel-Lindau syndrome, tuberous sclerosis complex, neurofibromatosis, as well as the succinate dehydrogenase B and D mutations in that list. So really, I'm going to use MEN1 as an example to begin with, because it's probably the sort of, I guess, more characteristic one to be able to explain this sort of phenomenon. As you can see, really not going into too much detail, everyone has chromosomes in the body, there's 23 pairs, and as you can see in this particular mutation, you have a defective gene in one of the chromosomes in that location. In there you can see the chromosomes split up into two halves, there's a P and a Q arm, and this mutation occurs in that longer Q arm in that specific point. And this mutation, as well as a lot of the mutations in neuroendocrine tumours, are autosomal dominant. So what that means is, and I'll explain that soon, is that you can have basically one defective mutation on one of the chromosomes, and just having that one defective mutation can then cause you to have the disease and then the clinical symptoms. So even having one adult parent that has this mutation, they can pass it on to their children. So you don't need both parents to have, you only need one adult, which is why these mutations occur so frequently once they become established, and why they can be passed down through many, many generations, ongoing, as long as people are having children in that disease. And 90% of individuals that are diagnosed with MEN1 will have an affected parent. So it's not as common to be a sort of what we call a sporadic mutation, which just happened by chance. So, if you've been diagnosed, there's a very high likelihood you have either a parent or another family member that has this condition. And as I said, there's a 50% chance of passing it down to your children. Now, just to explain this is just an example. This isn't a real family, but this can definitely be someone's, is a very, easy example to characterize. Here you can see this is looking at 3 generations. So at the top in number 1, we have the grandparents, and as you can see, the coloured squares indicate an affected male, and the coloured circles an affected female. So you can see that the grandmother, who is now deceased, that's why there's a line through the circle, has passed on the mutation to 2 daughters and 1 son. And then, as you can see, in the first family, which is the 3 on my side is on the left, on your side would be the right, you can see that has then been passed on to the 3rd generation. There's a daughter and a son affected. In the middle, you can see that although the grandmother passed it on to her daughter, the family has not been affected as per this, because as I said, there's a 50% chance. And then in the last family, you can see that the mother has the mutation, has passed on to 2 of her daughters. So this just goes to show, how prevalent this can be once someone has the mutation, and why it's really important to be able to identify this and ask other family members and undergo screening and, have genetic counselling, because this is such a prevalent type condition that can just keep going on in generations. And really talking about why exactly having a mutation causes you to have an increased risk of cancer compared to the general population. So I'm basically going to talk about MEN1 in this example. So that gene, MEN1, produces a protein called menin. And that menin is thought to be a tumour suppressor gene. And what do I mean by tumour suppressor? So in the body, when you have cells dividing, like naturally, they're regenerating, you regenerate your skin, you regenerate the lining of your GI tract, all sorts of processes occur. Normally there's a balance between these genes that cause growth. You can see in the example there, you've got the proto-oncogene gene, which is like the car having gas moving forward, and then you've also got this tumour suppression gene sort of as the brake. So you've got a good balance. So the cells are replicating at a normal rate. They're not replicating too slowly or too quickly, and obviously you've sort of got this protection against cells being getting formed too quickly and becoming cancerous. So when you have one defective gene, you have an increased risk of having less of the tumour suppression, and so then you have a sort of a more of a chance of then developing a cancer because you don't have that break. So you sort of have more of a drive to develop more cells and more cancer. And just to explain this in this diagram, probably be a bit easier, if someone has a mutation such as MEN1, or this could be another, SDHB, D, von Hippel-Lindau syndrome, any sort of neuroendocrine tumour, and it's a known mutation that they've acquired from birth, you can see they've already got one defective gene. So you can see that one of them's already crossed off. And then during their life, all they have to have is one more mutation, and then they've got two defective genes, and then they've got, they can develop a cancer, which is why it's so much more common for cancers to develop when you've already got one defective gene. But you can see in the non-hereditary, which is sort of all the other cancers people develop during their life, they really need two genes to be defective, and they need two events to, harbour a mutation. And a lot of times your body will repair, or they'll discard the gene that's defective. So they've got a lot more chance. That's why it's so much more common to have a tumour when you've already got one defective gene. So it's something called the two-hit hypothesis here. And using MEN1 as an example again, when we talk about the three Ps, we're really referring to pituitary, parathyroid, and the pancreatic endocrine tumours. And as you can see in the percentages, not everyone develops every kind of tumour. And you can see that almost everyone will develop a parathyroid tumour, but other people, some people will develop the pituitary tumour, some people will develop the pancreatic tumours, and that really depends on, as I said, this chance, these mutations in the body, but you've obviously got a much higher risk. And just to illustrate that further, this is a study of over 100 patients with MEN1, and this is just looking at what age did they develop the certain mutations. So as I mentioned, almost everyone develops the parathyroid tumour, so you can see that it's got the biggest curve at the top. So you can see that the average age is between 21 to 30 is sort of the peak, but you can see that people are developing it even at the age of 15 or earlier. It really depends. And you can see some of the other tumours they develop. There is obviously a peak in the middle age, but people are still developing these as they get older. So really, just showing you that because of these genetic mutations, not everyone will develop everything, but there is a high chance of developing something in this condition during your lifetime. And if we look now at MEN1 again, and looking at sort of what if someone had presented to their general practitioner or to a specialist and they had something on the left-hand side of that table, so the factors, so say they had a isolated parathyroid adenoma before age 40, just by itself, the chance of them having MEN1 is 5 to 13%. And then if they had a thymic neuroendocrine plasia towards the bottom at any age, they've got a 25%. So the more sort of clinical signs or features they have, the more likely they are to have a neuroendocrine tumour or a genetic variant. And obviously at the top, the highest chance if you've got a family history of MEN1 and you've got the classical signs and symptoms, you've got a really high chance. So really this just goes to show that, some of these tumours, even though I say that they're rare, once you've got them, there's a high chance of you having a mutation depending on the subtype, and that's why it's really important to be able to see people and get the diagnosis and have screening for other family members. Briefly talking about von Hippel-Lindau disease. So this is a disease essentially where you've got a gene that helps control blood vessel growth in certain parts of the body. Again, it's on a specific site of a chromosome, and you can see again it's autosomal dominant, like we mentioned, 50% chance of passing it on, and 80% of individuals with this disease actually have an affected parent. So even though earlier I said most of these conditions are not a family condition, if you have this, then there's a very high chance you'll have a family member that has it. And they might have not yet been diagnosed or screened, and this is an opportunity to then get this done. And as you can see on the right-hand side, we've got benign tumours and cancers. So this just illustrates that even though you have this mutation, a lot of the time you'll have development of tumours which are benign, but there's a very high chance of having them. And you can see as you go down the list, they might be benign, but they also, in some cases, might be metastatic. And you do have an 80% chance of developing kidney cancer in addition to this disease. But not everyone will develop the cancer, but they will develop a lot of those other tumours. And now, looking at neurofibromatosis 1, essentially this is again like a tumour protection gene, and on another chromosome again, it's a very specific location. Again, autosomal dominant, and 50% of individuals with this will have an affected parent. So really, you know, if you have these conditions, it's really likely that you'll have at least a family member that has this as well. They might have not been diagnosed, they might have passed away, and you know, this is what we are dealing with in this condition. And you can see pretty much everyone with this condition will have neurofibromas, which is one of the clinical signs. But then looking at the cancers, it's really, you know, a lottery sometimes of what you're going to get, because as I mentioned, it is a genetic chance. But there is a proportion of patients that do develop these, and essentially this is why it's really important that we have ongoing follow-up and screening, because you know, you can't really predict when you're going to get this, and really important to recognise the signs as well of these symptoms, and be able to see someone and seek the right investigations. And now, moving on to paragangliomas and pheochromocytomas. So the difference is the pheochromocytoses are tumours that are arising in the adrenal glands. So those are glands that sit right above your kidneys. And the paragangliomas are basically other parts of the nervous system. So they can be in your neck, your chest, your abdomen, or pelvis. And that's a chance thing as well. And it really depends on what sort of mutation you have. So most commonly we see these in the SDHB and D mutations. Looking there on the bottom left, basically you've got A, B, C, D. It forms this complex, and essentially if you have a defect in one of the genes, that causes, you know, you have a propensity to develop cancer. And really depending on the gene, that sort of, you know, depends your chance of a cancer developing. And also, I'm not going to go into too much detail, but sometimes if you inherited from your father or your mother, also gives you a different chance of developing cancer. So I see a lot of patients in the clinic, you know, they're coming into our clinic, they maybe get seen once a year or every 6 months, and they wonder, why am I getting screened every year with a blood test or with imaging? It's because, you know, you've got this ongoing chance. They might not have anything for 10 years, and then suddenly, you know, a new tumour will be picked up by a blood test or by imaging. Because a lot of these tumours, I'm sure you've had experience where you might not actually have any symptoms, or it might be so small that it's actually not causing any major issue or pain, because a lot of them sit in organs or areas where it's not really vital. So, you know, they're not going to be in the middle of your neck obstructing your breathing, or they're not going to be sitting in one of the blood vessels. But that's why sometimes with these tests, like the blood test and imaging combination, that helps us pick it up even before, you know, we would be able to, when you start having symptoms. Obviously, if the tumours are secreting hormones, you might have other symptoms, but that's why it's really important, because if we catch them early on when they're very small, there's a lot of treatments available. There can even be surgery, there can be directed immunotherapy, which I'm sure Jeremy will be talking about. And, you know, this is why these genes, you know, and these mutations are really important to identify, because then we know sort of what's your relative risk, what's your sort of chance, and how we can screen them and, you know, continue blood tests. And as you can see here as well, paragangliomas and pheochromocytomas can also be associated with a lot of the other conditions, such as MEN2, von Hippel-Lindau disease, NF1. And you can see, depends on the gene that's affected, and that's also got, you know, a chance of cancer in that range. So I know I've alluded to this before about genetic screening, and essentially I want to reiterate that if you've been diagnosed with a neuroendocrine tumour, or you know someone that has, you know, family members, including children, can have genetic testing. You know, they can be referred to a genetic counsellor. You don't have to have the discussion with them. Sometimes the GP might not feel comfortable having a discussion with them because they're not the specialist in the area. They don't always have the right tools and resources and knowledge. So it's really important for either the specialist or the GP or anyone that you know, is interested, refers on to a genetic specialist, and then they can have that discussion. And it doesn't mean that when they get there, they're going to, you know, get their blood test and, you know, do the testing. They can have a discussion. They can decide whether it's appropriate, whether the family wants it. Everyone is different. We've definitely had patients in the clinic where someone's been affected and they have a brother or a sister who don't want to have the testing. But, you know, at least if they have the information about it, they can make their decision. They might want to have the testing further on, or they might want to have children. And the other thing that is really changed in the last sort of 10 to 20 years is now we have techniques in terms of pregnancy that can help, give a diagnosis prior to conception or pregnancy going on if the patients don't want to have a mutation passed on. So the only way we can do that is if we know if the patient or the parent has that mutation. So really, it's really important to get advice about this. And so now to summarise the takeaway points, really neuroendocrine tumours, 7th most diagnosed cancer in Australia. I was shocked as well. I didn't think it was that common. Really, when you always talk about the breast cancer, the lung cancer, and this is really an unrecognised area, and it takes an average 5 years to reach the correct diagnosis. It can be seen in several of these inherited familial syndromes. Most of them are inherited and autosomal dominant, so very high chance of passing it on to your offspring if you do have the disease. And not everyone will develop every type of tumour of the disease, but obviously some of them have more chance than others, and that's why it's really important to have regular screening and follow-up. And as I said, it's very also important to refer to appropriate genetic screening and counselling for other family members. So thank you for listening, and as I said, we've got a lot of questions if you need to discuss them after.
So our next presenter is Dr. Jeremy Power, and Dr. Power qualified with a Bachelor of Medicine and Bachelor of Surgery from Monash University in Melbourne in 2001. He became a Fellow of the Australasian College of Physicians, Medical Oncology in 2009, and during his training he worked in a range of cancer centres in Victoria. He moved to Tasmania in 2010, and prior to this, Dr. Power worked as a medical oncologist at the Peter MacCallum Cancer Centre in Melbourne. He has a strong interest in clinical trials and is experienced principal investigator for a range of medical oncology clinical trials, and he's a member, hopefully still, of the Cancer Council Tasmanian Medical Advisory Board and is the lead supervisor of medical oncology training at the Northern Cancer Centre. So Dr. Power sees his work with patients and their families as a privilege, and he values the collaborative approach to care provided at WP Holman Clinic. So thank you so much.
Thank you very much. Well, thank you for that lovely introduction, and thank you very much for the invitation to speak today. That was an excellent presentation from Thomas, and I've certainly got some, certainly a hard act to follow, particularly if I can't find my slides on this thing.
Can you sing and dance?
So, and if I can just bring up my slides. Oh no. Sorry, I've got a bit of a problem here in that I can't see my notes on this slide, on these slides. Sorry. Sorry. Top in the middle, view. All right, so my apologies, I don't know how to change this, and I'm very sorry. But look, I'll just get on with it and I'll do my best. Sorry about that. So not many people look forward to seeing a medical oncologist like me, and unfortunately there's good reason for that. But I've decided to call my title Good News because often with these sort of tumours, and with a lot of tumours these days, it's not all doom and gloom. There's a lot we can do to help, and particularly for neuroendocrine tumours, we have a lot of treatment options and a lot of ways that we can be of assistance. So what's the problem with these tumours? If you look at on the top right there, what we see is that a tumour is really a normal cell that goes rogue. Under a microscope, you can see normal cells, and over time, unfortunately, some of them become abnormal cells, and as they become more and more abnormal, they start to grow and replicate and take over the normal tissue, and then the wretched things can unfortunately then escape the normal tissue and get into the blood vessels or get into lymphatics and spread and head off into other areas. On the left, we have just an overview of neuroendocrine tumours and where they're most likely to come from. The majority of them arise in the gut, particularly the small intestine, which is basically most of the contents of your belly are the small intestine, but there's, with a few other things. They can also arise in the pancreas, which is an organ that often gets forgotten about. It sort of sits in the middle of all the other organs and does a few things like helps you digest food and also makes insulin. They're also in the lung, and there are some other rarer types of neuroendocrine tumour that arise in the adrenal gland and a few other organs as well, and the parathyroid. But by and large, most of them come from the gastrointestinal tract. On the bottom right there, we've got a really, really magnified view of one of these abnormal cells that make up a neuroendocrine tumour. That picture's been taken using a very special and expensive machine called an electron microscope. And you can see, in the diagram above, there's a nucleus and it's surrounded by some fluid. And those little dark dots you can see on the bottom right there are what we call secretory granules, and that's just a fancy term for saying they contain hormones. One of the problems that we often see with neuroendocrine tumours is this thing called carcinoid syndrome, and unfortunately those secretory granules contain some stuff called serotonin that causes that carcinoid syndrome, and that's why you get that problem with some small intestine neuroendocrine tumours. They can also create a range of other hormones which sometimes causes problems as well. And unfortunately, as I mentioned, they can spread around the body. And so what we're looking at here is a PET scan, and this is from a patient who had a neuroendocrine tumour that originally arose in the small bowel, and unfortunately it's spread into the bloodstream and it's lodged in many other tissues around the body, like the liver, some lymph nodes and the bones. When tumours develop, sometimes you can take them out with surgery, and really a medical oncologist doesn't get too involved in the management in that situation. But unfortunately, all too often we find them and they've spread to other parts of the body, and that's when medical oncologists like myself might get involved in your care. So I already talked about carcinoid syndrome. So what on earth is a medical oncologist? Well, we specialise in using medications to treat cancers, and that is in contrast to, say, someone like a radiation oncologist who uses radiotherapy, or a surgeon who uses surgery. And we work as part of a multidisciplinary team, so a lot of things can happen in neuroendocrine tumours, and so we don't just use medical oncologists to help. We also have surgeons, radiation oncologists, endocrinologists like Thomas, GPs of course, and a range of other people, particularly care coordinators and allied health, but also a few other specialties as well, like palliative care physicians and nuclear medicine physicians, and anyone else whose assistance might be helpful or necessary. So what do? Well, we are highly trained and informed and qualified in the safe and effective use of medications and other treatment modalities. We remain up to date with evidence and data supporting treatments, and if you're silly enough to sign up to become a medical oncologist, it means you have to keep learning non-stop for your entire career. We're aware of and participate in ongoing research into better treatments, and we often play a coordinating role in care. So we tend to have a very long-term relationship with people with these, unlucky enough to have these diseases. And we tend to be the ones who see people like yourselves most frequently. And we're there to make sure that the delivery of care is optimal to optimise outcomes, and particularly for neuroendocrine tumours that are not suitable for surgical removal. So what on earth are we trying to do? Well, there's a few aims. Number one is to relieve and prevent suffering, of course, and that means symptom control, supportive care, and monitoring for complications. So the small bowel neuroendocrine tumours, for example, you can have heart problems with them, and so we'll keep an eye out for those. We aim to improve quality of life and maintain it at the optimal achievable level for as long as possible. So again, symptom control and monitoring for complications as part of that, but also more active measures to control disease and to prolong survival as much as possible if we can't achieve a cure. And of course to improve knowledge, understanding and care of neuroendocrine tumours as well. So what sort of treatments might we use? Well, many of you have probably used or come across or heard of somatostatin analogues. So it was discovered many years ago that the cells that we were talking about earlier that make up these neuroendocrine tumours have somatostatin receptors on them, and when these are activated, they actually act as an off switch on the neuroendocrine tumours. And somatostatin analogues basically hit the off switch on these tumours, and that makes them very effective at controlling hormone secretion. So the carcinoid syndrome or other hormone syndromes that these tumours cause often respond very quickly when we start a somatostatin analogue. They also, however, reduce the drive inside the neuroendocrine tumours to replicate and grow and spread, and they also sometimes activate a self-destruct signal that these cells have in them, and hence they can also kill off a lot of these cells as well and stop them from growing and spreading. And they've been a long-standing mainstay of treatment for neuroendocrine tumours. And so they're usually a monthly injection, and sometimes they can cause some diarrhoea, but they're often very well tolerated. And people can be on them for years and years and years. I look after one patient who has been having these continuously since 2003, so that's 20 years. And still their cancer is under very good control, and they're very well and leading a fit and active life. So these treatments are very, very good for the right person. Chemotherapy is a bit of a bogeyman, but there's no need for it to be. It's a treatment that is administered into the veins or via a tablet, and basically they're drugs that are designed to be toxic to cancer cells, and they use the bloodstream to deliver the drugs all around the body. So no matter where a neuroendocrine tumour cell is hiding, and that PET scan showed that it can go everywhere in the body, if it's within reach of the bloodstream, the chemotherapy will get to it and hopefully poison it off. It's got a bit of a bad reputation, and it does tend to work better in cancer cells that are growing quickly. So although a lot of neuroendocrine tumours don't grow quickly, some of them do, and some of them start off not growing very quickly, but then grow more rapidly years later or sometime down the track. The chemotherapy tends to work better in those people whose tumour is growing faster. And you can see, and we tend to monitor how it's working with scans. And again, my slide hasn't really worked properly there. You can see the caption buried behind the scan at the bottom. Sorry about that, but if you look on the bottom left, you can see a big lump in the middle of the scan, and after chemo, you can see that lump has pretty much gone away. And so you can monitor how it's working, and in that way, you can test whether the chemotherapy is really worth it, because they can cause some side effects, but if it's shrinking a cancer like that, it might be worth it. If it's not shrinking, then maybe the side effects and problems aren't worth it. So, so hopefully, you can minimise problems by keeping an eye on it. And often they're not as toxic as people think. The other tool that we've got, and there's lots of different types of chemotherapy, I should say, and it's not uncommon for a person who lives with a neuroendocrine tumour for many years to go through multiple different lines of chemotherapy, and indeed targeted therapy, which I'm about to talk about. And these ones interfere with machinery inside cancer cells. They prevent the growth of cells by interfering with the function, and can kill the cells directly if they hit targets that are necessary for the cell to live. The side effects can be a bit problematic, and again, you can monitor the effectiveness with scans. There's a couple of drugs we have readily available called sunitinib and everolimus, and a lot of people with the neuroendocrine tumours will have a course of those drugs. The other thing we're always trying to do, though, is looking for new treatments, and and that's why getting an understanding of cancer cells and how they behave is so important, because we need to identify the chinks in the cancer cell's armour and how to kill it off. And some people will be eligible to participate in research or clinical trials, and this, first of all, can sometimes give access to a treatment that otherwise isn't available, particularly if there isn't a treatment that is likely to be effective or helpful. When we to develop a new treatment, first of all, we do lots of research and hopefully identify a chink in a cancer cell's armament, and then try to identify a way of targeting that chink and hitting that chink. And once we develop a new chemotherapy or other treatment, we then start to do clinical trials to see if it works. Usually after doing experiments in cell lines where cancer is grown in the lab and tested. Initially we do tests in small numbers of people called phase 1 trials, that will usually, for people who don't have any other treatments, to work out whether the therapies are safe, and then if they're safe, and we then go to a phase 2 trial where we're trying to see, is there really any hope that this drug does actually work in real people? Usually we're looking to test a few dozen, maybe 50, maybe 100 patients, and they're quite an undertaking for people who are participating. You need to have a lot of tests. Sometimes you need to travel for them because they're not usually open everywhere. We are looking to see how the body handles the drug, and what percentage of people perhaps we see some tumour shrinkage or some evidence that the drug or the new treatment is having the desired effect. If it looks promising in the phase 2 treatment and it doesn't appear to be unsafe, then we move on to phase 3 trials, which are usually randomised trials. So usually comparing the new treatment to no treatment or a placebo, or a new treatment to a previous standard treatment. So usually these trials are big undertakings. They're run at lots of centres, and again, there's a fair bit to them if you're going to participate. Once hopefully after a phase 3 trial, we know for sure whether the new treatment is effective. We can only legally prescribe drugs for condition if it's approved by the Therapeutic Goods Administration. And they need to see evidence, usually from at least one phase 3 trial, that the drug is safe and effective. And then the drug becomes registered. And there's an organisation called the Pharmaceutical Benefits Advisory Committee that works out whether a drug is cost effective. So is it worth spending taxpayer money to make the drug available? And then the federal government makes a decision on whether to add it to the pharmaceutical benefits scheme. So that's the process that we tend to go through for getting new treatments. I hope that made sense. I feel like I talked a lot, but I hope it made sense. And all the treatments we have available today have come through that process. So here, for example, is the results of the phase 3 trial of using octreotide LAR, which is a somatostatin analogue. And in this trial, around about 100 patients agreed to go on it, and they were able to show that the people who were on the trial did better than those who had a placebo. They had longer time before there was any problems or any progression of the cancer. So that trial was published in 2008, and because of that, we now have this drug available for a lot of people with neuroendocrine tumours. And here's another trial looking at everolimus, which is one of the targeted therapies I mentioned. And again, it's all because of the work that's done in research and people volunteering to be patients on clinical trials that we can prove these new treatments are available, build up an argument for them to be generally available for the population. And thanks to that, we now have everolimus available as well. So that's a look at the treatments we have readily available for neuroendocrine tumours, but that's not all. And those are the ones really that medical oncologists will use and be primarily responsible for. But that's obviously not all the treatment. Surgery to remove tumour if it hasn't spread. Sometimes a partial removal can be done to reduce carcinoid syndrome. That is often a big problem. And sometimes there's complications of surgery, like bowel obstructions, or maybe problems with the heart valves in those people who have a carcinoid tumour. There's a treatment called peptide receptor radionuclide therapy, which is very important. And it's not available in Tasmania, but I certainly refer a lot of people interstate to centres that have it available. And I'll talk a little bit more about that. But radiotherapy, which is the use of gamma rays generated in a big machine called a linear accelerator to hit trouble spots in the body, like if you've got pain from a tumour spot on a bone, for example, that could be very effective in getting rid of that. And of course, comfort and supportive measures to relieve symptoms and to assist people who are having trouble related to their cancer is also very important. So, talking a little bit more about peptide receptor radionuclide therapy, this targets again the somatostatin receptors that so many of these tumours express. On the cancer cell on the top right there, you can see those little purple things. They're the somatostatin receptors, and basically they link a radioactive isotope to a peptide that binds to the receptor. That is administered into a vein. It binds to the cancer cells, and basically the cancer cells pull this whole complex into themselves, and you end up with a huge dose of radiation inside the cancer cells. And this is a very, very effective treatment for neuroendocrine tumours. And just to bring back that slide, you can tell whether it's going to work or not, because if you've done one of these dotatate PET scans, you can see exactly where the peptide receptor radionuclide therapy is going to concentrate itself, because it basically hits exactly the same spots. Once again, it's a very safe and non-toxic treatment, this one. And I would say most patients with a neuroendocrine tumour that has spread will have this at some point during the course of their treatment. Usually given once every 6 or 8 weeks initially, and usually very, very well tolerated, and you can have repeat courses along the way. So if it works well the first time, then it grows back, then you can do it again often. And very, very effective tool in controlling these neuroendocrine tumours. So I guess in summary, we, as oncologists, we have a lot of things we can do to help. Really, a lot of cancers, and neuroendocrine tumour is no exception, is often a disease that people live with. In some ways it's a bit like diabetes or something where it needs some management, it needs ongoing attention, but people tend to live for a long time with it, and there's lots we can do to help, and often people live with these tumours for many, many years. So to optimise the care of people with neuroendocrine tumours, I think there's a few things I always bear in mind. First of all, we have to listen and make sure that we're hearing what people are telling us, and that we're working out what the problems are, and whether they be physical or psychological or social, and then making sure that we're being very strategic about the way that we use all these options, and use whichever of the many effective therapies are available when they're most likely to be effective. And most people with the neuroendocrine tumour, as I said, will have multiple successive lines of treatment over years, often with great success. We always prioritise control of symptoms. There is absolutely no benefit in most cases to people suffering. Although I'm here speaking about what a medical oncologist does, there are many other people who have skills and expertise that is valuable, and it's incumbent in my job to help you to make the most of all those people as well. So I hope that's given you some sort of insight into where I fit into care of people with these tumours, and again, I'm happy to have a chat to anybody who wants to ask any questions.
Perfect. Thanks so much.
Thank you.
And our last speaker is Yasmin Innocenti, who works here at the Cancer Council, and she's going to give us an overview of what is available.
Yeah, definitely.
We need to. Someone. It's yours.
Oh, sorry. I'm just going to check the sound works. So I'm just going to check that first.
Okay.
So that works all good, and then I'll keep going. I'll just quickly introduce myself. Yeah, I'm Yasmin. My background is I actually studied in Oxford in England. I did nursing, and in my management placement, which is our final placement of university in nursing in the UK, I worked at the Churchill Oncology Hospital in head and neck, and that's where I found my passion for working with people who have been diagnosed with cancer. When I came to Tasmania, I started working on Ward 5D, which is the inpatient ward here at the LGH. So I worked there, and later I also started working in the Holman Clinic, which is the outpatients chemotherapy, giving chemotherapy to patients, and then I also did the prostate cancer clinical nurse coordinator role as well. So I've had quite a bit of background in oncology, and when I couldn't work on the floor full time anymore, a job opportunity came up here to be one of the coordinators, And I was so excited when I was able to get the role and be able to support people with oncology, but in a different way. So I'll just pull up my presentation. I'm just going to check if this video works before. Perfect. So I just want to, before I start my presentation, acknowledge the traditional custodians on the lands in which we work, live and pay our respects to elders past, present and emerging. And I also want to provide you all a warm welcome to our Northern Cancer Centre today. So Cancer Tasmania has been designed to provide a safe space for people to come into outside of the hospital. We provide psychosocial and peer support here, and we were established in 1995. We were established not long after the Maggie's model in the UK, and the Maggie's model was actually a model discovered by a patient who needed some more psychosocial support and to get out of the hospital. So we were inspired by that model that was originated there, and we are a statewide charity. Cancer Australia is national, but we've also split off into different states and territories, and Cancer Tasmania is within Cancer Tasmania. So we currently have over 44 members of staff, and we have so many volunteers that help us. We are governed by a board of directors, and even though we do have a small amount of government funding, we do have 85% of our funding does come through donations and community fundraisers. So things like Daffodil, Biggest Morning Tea, Relay for Life, all those things that you see in the community that we do help to basically put money back into the centre so we can provide support to people impacted and diagnosed with cancer. And every dollar raised in Tasmania stays in Tasmania. So our mission is to minimise the incidence and impact of cancer on all Tasmanians, and we do this by providing supportive care services to people affected by cancer. We do this as well by investing in cancer prevention programs. So we have a prevention team in our southern and northern centres, and they go off into the community and provide messaging to people. So things like our Sunsafe Slip, Slop, Slap, Seek, Slide, so things like that. And they're also working on a program where they're actually doing early intervention into primary schools and secondary schools to get messaging out to young people in the community. We also, with our fundraising, we help to fund research to put into many of the important resources that we have to be able to provide to people with a cancer diagnosis or a friend, a family who would like to know more about their loved one with a cancer diagnosis. So we have 3 support centres around Tasmania, the Northern Centre, which you're in now. We have one down in Sandy Bay, and then we also have one in Devonport. But very recently, we've been lucky enough for people who are from the Northwest. We've actually moved into the Northwest Regional 3 days a week, and we're able to support people who are going through treatment, radiotherapy, chemotherapy in the hospital, saving them a trip to Devonport if they're from the other side of Burnie. So here's some of our staff. So in the top left, we have Chris and Stan in the Northwest. So if you're ever in there, you'll see those guys in there. Myself, Louise and Emma, we work here in the Northern Centre. And down in the South, we have Louise, Juliana, Fiona and Geraldine. Now, we do help people out. We help each other out statewide. So if you guys ever come in, you might see one of the faces on the screen. Then we also have our amazing supportive care volunteers. Now, we couldn't do what we do without the volunteers. They're the first people that you normally see when you come into the centre. They provide a nice, warm, welcoming hello and provide you with a hot drink or cold drink. But they also help out with all of our fundraising and events. They try and help out with our Daffodil Days. We have the Gala Ball tomorrow night. They are just amazing humans. Some of them had been impacted by cancer themselves and now are in remission and want to give back to other people who are impacted and diagnosed with cancer. So we're very grateful that we have access to wonderful people like you see on the screen. So around 10 Tasmanians are diagnosed with cancer each day. So with that, we provide this centre not only for the person with the diagnosis, but like I said before, also their loved ones. So I've got a little short video I'd like to share with you guys that just gives you a bit of a perspective from a couple of clients that we've had in the centre, so you have a better idea of what the impact that we've had on them.
We get calls from school teachers who have children in their classes whose parents might have cancer. We get calls from people who have cancer themselves, from their husbands, wives. The person in front of us is our client. So even if they ring on behalf of their husband who's got a diagnosis, our focus is on the person who's actually running.
Coming here was a great benefit to me to share my thoughts and ideas and get other people's feedback on how things were happening. Talking to people to understand where you're coming from, where you're at, is really important. There's a lot of people out there saying, "Any I'm there to help, I'm here for you if you want me." They're just words, but coming from someone like yourself and from the organisation, it was more sincere. Made a big difference to me, a big difference.
Before I came in, I was feeling a bit fragile, so I thought this might be a good place to come and see if there's any sort of services or help. And when I came in, the first thing that I sort of felt was this incredible feeling of love and welcoming. It gave me a place to come where I could meet other people who had also been on a similar journey, to be able to talk about things that we were going through and problems that we'd had post-cancer. Mentally, emotionally, that was really the main thing. And then to find out that there was actually things that you could do here which have been so beautiful.
So most of the things that we offer to clients and people coming to the centre are delivered in the centre. And we offer things such as individual support. Now this can be by appointment or you can just drop in. As you guys have seen today, we have the parking out the back for anyone to utilise who needs it, and this centre also. So we can do face-to-face individual supports. Now we don't have counsellors here at the Cancer Council, but we do have people with lots of different backgrounds that can listen and see what's going on your cancer journey, where we can help identify unmet needs and see what we can do to support you. And we can do this, like I said, face to face, but if that's not for you, you can give us a call, you can send us an email, and if you don't want to call our centre specifically, we do have the national number, the 131120 number as well. So what do we do in the centres? So we have group-based peer support, so we have support groups that we can run for people. The support groups that we have currently in the Northern Centre is our men's cancer support group, our breast cancer support group, and our all cancer support group. So this is giving the opportunity to people to have some social support and build a community connection. Coming into the centre isn't easy for everyone, especially if you're going through treatment and you're tired, immunocompromised. So we do have national telephone support groups as well that people can access. Support groups aren't for everyone though. Some people don't really particularly want to come in and sit down and have a chat, and that's absolutely fine. Everyone is different. So we also have activity-based peer support groups. In the Northern Centre at the moment, we run a craft group and a cuppa every second Thursday, and this gives people an opportunity to come in, do something, and have a chat to other people if they feel like it. It's no pressure. You can focus on an activity, and then if you feel like interjecting into a conversation, then you're more than welcome. We also have our games group that will start next month, and that's just an opportunity for people to come together, do something such as play cards or Scrabble or Monopoly, and be able to have that social connection and chat if they feel like it. In the north, we're hoping to get our walking group back up and running in the new year, and this is again another opportunity for people to go and do some exercise, which has shown huge benefits in cancer diagnosis, and have a chat if they fancy it, but they don't have to. Often the first time that we meet someone is through our practical support. Now, when someone's first diagnosed with cancer, as I'm sure most of you know, it's a massive whirlwind. There's so many things to think about and consider. And one of them is, oh my goodness, can I work? Do I need surgery? I've got children, I need to look after them. So we do offer financial support here. That is done through a referrer, so people like your social worker, your oncologist, your clinical nurse coordinator, anyone on part of your oncology team can refer into us for financial support if you express that you need assistance. We also have our wig service that we can provide you with a wig if you lose your hair because of cancer treatments or have thinning hair because of cancer treatments. And we can do a one-to-one, a private appointment where we find something that makes you feel comfortable. If a wig's not for you, that's absolutely fine. We also have lots of headwear and turbans and things, and places in the community where you can access more things as well. For a lot of people who can't drive or get to treatment, we do have our transport to treatment service. So that's a service that picks you up from home, brings you to the Holman Clinic for your treatment, and then picks you up after treatment, takes you home. This again is a referral from one of your healthcare professionals into this service, and it's there for people to make sure we can get you there. We also offer Centrelink appointments to people here in the centre. I don't know about any of you, but going down to Centrelink just for me is not fun. So we've provided an experience where it's by appointment, you're not going to be waiting around, you're in the safety of the centre, you're not around other people, it's just to provide something else to someone. And we do have urgent appointments for those people who need it. We also have our pro bono service. Now, a lot of people don't think about this straight away, or when they first get a cancer diagnosis, that they haven't got all their affairs in order. For people who need it, we can provide assistance with a will, a power of attorney, and enduring guardian free of charge. It is means tested, but it's another service there for people who need it. We offer complementary therapies here in the Northern Centre. So we currently offer up here oncology massage. Now there's a lot going on, there's a lot to think about, there's not a lot of time for self-care, so we try and offer a massage to help people slow down for a little bit and do something for themselves through all the chaos. We also have here exercise physiology programs. People who have to go through surgery or chemo or radiation can get quite deconditioned post, so we offer this service as a starter to get you back on your track to back to being yourself. We also have Tai Chi and mindfulness. Now, working for 5 years in Launceston General, I've never thought of mindfulness. I've never thought of it as something I would ever do or ever suggest to someone. But when I first started here, I had a gentleman who had been diagnosed with leukemia about 10 years ago. And he'd gone through treatment, and he'd had to go through a stem cell transplant and a complication post-transplant. But he got through all of that and was 10 years in remission. And this December, just gone, he came back into us with a stage 4 glioblastoma, which is a brain cancer, which is incurable, and his prognosis was only a couple of months. And he'd gone from being a very happy, positive human to becoming very angry and unable to regulate emotions or be present in that moment. I offered mindfulness to him, and he said to me, nah, not doing that, not interested. Came back a few weeks later and said, actually, I would like to try the mindfulness. And came and did 3 weeks of the program, and at the end of it he just said, thank you so much, I actually really needed that, and now I can enjoy, you know, the little bit of life I've got left. It was really a big eye-opener for me to notice how powerful that was for that person and other people that have attended. So we have lots of resources available, and I have noticed a lot of people come in and said, I've been diagnosed with this cancer, and I went onto Google last night and it told me this and this and this. And I'm like, oh, okay. So all of the resources that we have here are evidence-based. And what we don't have in a hard copy, we do have online. And for people who can't come into the centre, we can send things via email. And if you don't have internet and you're not tech savvy and don't have an email address, that's absolutely fine. We can get things sent to your postal address as well. We're here to support you where you need it. So you can tell us what you need, and we'll try our best to cater to what we like within our means to do what we can to help you. We also provide information and resources to healthcare professionals, such as presentations about our centre and our services, so they can tell patients about what we have to offer and what's available. For people who find it difficult to read or just don't like reading, we do have podcasts and things that we can send via email as well. And we have all these resources available on our website. For people who have got children or with a diagnosis, or you've had the diagnosis and you have children, we do have support for under 25-year-olds. So we have the Rachel and Jai Foundation, which is an initial payment of $1,000 to any child under the age of 18 diagnosed with cancer. And also normally with these this age demographic, they don't get treated here in Tasmania. They have to go to Melbourne for their treatment. So we do a travel assistance fund of $1,000 as well to help those people out. The Rachel and Jai Foundation was actually founded by two families who had two young kids diagnosed very young with leukemia. They went to Victoria and noticed how hard it was on some of the parents, especially some single parents who had to take time off work and just could not get by. So they started this to help people in Tasmania who have a child under the age of 18 with a diagnosis. Under the age of 25, anyone impacted or diagnosed with cancer, we can also assist. Recently we had a young family, the mum got diagnosed with breast cancer. She was end of life palliative. She was 31. Her husband was 30, and they had kids aged 2, 4 and 6. And the dad came in for a Centrelink appointment and just said, look, my son came up to me with a soccer bill for the year, and it was either pay for soccer or pay for food. So we were able to not only pay for the soccer for that child, but we were able to assist the other children and get them food vouchers. And that family were just so grateful. For older children aged 16 to 25, we can help with support with a scholarship for their education in secondary school, university education, or if they do an apprenticeship or anything like that, we can help put towards from $500 to $2,000 for them. So if you ever need any more information, just please get in touch. And how do you get in touch? Well, any Tasmanian impacted or diagnosed through treatment, palliation or bereavement can come use our services, our centre, our parking, whatever you need. We do have some emails that we can send to you at any point. If you give us a call, we can send you an email. We do have an online referral. If you go onto Cancer Tasmania and type in referral, it should pop up, or you can give us a call. We have a generic number that's on there, and then we can also give you our centre number as well. You don't have to be do a referral. You can just pop in for a chat, a cuppa, whatever you really want, anytime. And if you want to stay in touch with what's going on in our centres, because we do run workshops and seminars and things like that, we do have a monthly supportive care e-news that we can sign people up to, or you can sign yourself up to online. Thank you very much.
So much, yes.
Thank you.
Now I am aware of the time, but are there any questions that anybody would like to ask? All absolutely blown away. There was one that was sent through to us. Can any of these medications cure carcinoid tumour in the lung? There's, and I'll possibly point to Jeremy for that one. Vitamin C 1000 milligrams intravenous, monoclonal antibodies, Yervoy, Keytruda, or CAR T cell therapy.
Yeah, so
Just if you don't
Could
mind
you
up
come
at the
to
podium.
so that we can get
so all those treatments hold great promise for cancer, for treatment of cancer in general. They don't. To be able to give a good answer on that question, we need more research. That's the bottom line. And certainly, though, I've seen some small studies that have suggested that there can be good responses particularly to the immunotherapy drugs that were mentioned there. I think Yervoy was one of them, and what were the other ones? CAR T.
Keytruda.
Keytruda, yep.
Monoclonal antibodies.
Yeah, so Keytruda and Yervoy are two types of immunotherapy, and there've certainly been some impressive responses. without good evidence in terms of a clinical trial, it is hard to know how well they work, who they work for, how many people they work for, and so I'd have to say at present they're still in the research phase, but there may well be availability of clinical trials again that people can participate in if they want to contribute to the effort to improve cancer treatments. The CAR T, and the same for CAR T. It's very much a research, very much in the research phase. But you know, maybe there's promise in the future. It'd be very hard for me to offer somebody any promise of a cure out of any of those treatments at this stage. But hopefully, as we learn more about them, that will change.
Thank you. Any other questions? Yes.
Mine's about the genetic testing. Each time that we've asked about it,
Yep.
We were told by our oncologist that it was unlikely that our children would have anything, simply because there wasn't any known history from my husband's family, but obviously that's not quite correct, that they should have testing.
And how do you go about it?
And how do we go about it? How do we get referred?
They're adult
to
children, so.
Yeah, so...
We have three adult children and 2 grandchildren. So.
Yeah, well, thanks for sharing the story, and obviously if anyone else has any questions as well regarding this. Look, without knowing the exact condition and the mutation and all the other things, it's hard for me to give you an exact answer of that particular genetic testing. As I alluded to, you know, some conditions are more common that will be inherited than others. It could be that, you know, potentially you're the... So do both of you have the mutation, or...?
No, just me.
Just you. So look, you know, there is a chance that you developed a mutation spontaneously, and there is no family history, and you know, unless it is difficult sometimes to check that. But I think if you are worried about your children having the mutation and they don't have any signs or any symptoms, I think the thing would be to, you know, get a referral potentially to a genetic counsellor and be able to get that thing going. Have you had that information?
No,
yeah.
We have asked, because just from information that we read, but yes, each time we were told that it was unlikely and it wasn't necessary. So.
Yeah, so it is tricky sometimes because a lot of the testing is not rebatable as well. So sometimes patients have to fund their own testing, and not everything is, you know, rebatable, and obviously there has to be a limit on how much the government will fund certain genetic diseases and things. But I think the best thing would be to get a referral to a genetic counsellor and specialist. Then they can decide on, they can explain things a bit more in detail. They can then, you know, talk about the options for testing. You know, sometimes not always a genetic test is done. Sometimes they might just do screening blood tests or imaging. Like, not every condition is, you know, has a genetic test for. And sometimes the mutations, like, you may, without knowing your condition, you may even have a mutation that no one else has. Like, it's not an exact type of mutation. It could be, you know, you could be the first person to have that mutation. So being able to test for that exact thing is not always, you know, it might not often show up. Like, for example, you might have a test, and, you know, if they test for that specific thing in your children, that if they don't have it, doesn't mean like 100% that they won't have it, you know, like another type of mutation or other things. So you have to be...
I should go off and get genetically tested, is what you're saying, to see what is actually wrong with me. Probably nothing's wrong with me, but what potentially may have caused it.
So have you had the genetic test?
No.
Oh, okay. So I think, yeah, so I think the first step would be for you to get referred for to a genetic counsellor and decide what kind of testing is available and what would be the next best step, because and then they can decide about, you know, if you do have a test, whether then your children need to be screened or not, or whether there's any other options available. That would be my path forward for that.
Can I just add something to that, please? So I was diagnosed with SDHB 21 years ago, and we actually see Professor Burgess. I might have come across you actually. And so I've been having screening for those 21 years, and I've just recently been diagnosed with a paraganglioma. Now, the reason we were diagnosed was because my son was 12 and he had a massive VO, and it was all very dramatic. But my point is, if he hadn't have been diagnosed, I wouldn't have been diagnosed with SDHB. I wouldn't have known that I had my paraganglioma until it had gotten to the point that it was, you know, stage 4 or something.
Yeah.
But so mine, I don't have any symptoms. I don't have any problems with it. I've just had radiation treatment at Peter Mac. And after we were diagnosed, my extended family were diagnosed, and I have a very large extended family, and 75% of my family who were tested have the gene. So brothers, sisters, cousins, aunties, uncles, I think there's about over 50 of us that have SDHB. We see Professor Burgess in Hobart. So that's why I think genetic testing is very important, because possibly,
That's why we were surprised.
yeah, I have adult
know.
children too. 2 of my children have the gene.
Right.
So, yeah, if you can get it done, that'd be, it'd be probably worthwhile.
Just to comment on that as well, you know, like it really does sometimes depend on the kind of cancer you have. Obviously, with the genetic testing and some of the other cancers that I'm sure Jeremy deals with, like lung cancer, breast cancer, they do genetic testing to see what kind of mutation they have, so then they can give you therapy for that particular gene. But not all cancers have that, and not all cancers, you know, even if you do have the testing, that doesn't necessarily mean 100% that, you know, it is something that's happened. Sort of, you've had the mutation your whole life at birth, or whether you've acquired it. But I think the main thing is to get more information and be able to look into it for your own peace of mind, and especially as, you know, can happen if your children are diagnosed with the condition, they can get the right screening and care they need before, you know, they do develop something down the line.
Thank you. Any others? No? Well, I'd like to thank Thomas, Jeremy and Yasmin for your presentations today, and I think they've been really helpful and covered a lot of different areas that we might not have covered in other forums. So just thank you to all of you for coming along. We're so pleased that we could come and provide this information to you, and look forward to 2 years' time. But please reach out at any time to NeuroEndocrine Cancer Australia. We're there for you, and there's a whole lot of resources up here. There's the flyers for the GPs to do their education. It's free, it's online, and they get points for it. And there's the toilet cards and the carcinocrisis cards as well. So help yourselves. They're there to be taken. And just thank you so much.